type B aortic dissection.
Thank you very much. Again, my disclosures of a research grant from Medtronic. Other disclosures that these are all my cases, so I'm going to be intrinsically biased. So the first thing you got to think about is whether if you have a acute type B dissection, you've diagnosed an acute type B dissection, is whether there's a malperfusion syndrome. The things that are going to be useful, of course, on exam, if you have a pulse discrepancy or cold extremity, that might indicate that there's a limb malperfusion. You got to look at the CT angiogram, of course, look at the EKG labs to see if there are any indicators of malperfusion. So the clinical complications related to dissections is broad. Of course, you can have anything from aortic ruptures to organ or limb malperfusion. When looking at type B dissections, about 30% are complicated. About 2/3 have malperfusion. About 1/3 can present with rupture. It's important to understand the type of obstruction that you're seeing. There's two forms, dynamic and static. If you have dynamic obstruction, it's very different than static obstruction, and they're managed differently. The treatment strategies, one, covering the entry tear. This will manage most dynamic obstruction. Then identify and manage any fixed obstruction. You may need to stent the obstructed branch, as we've seen in the previous presentation, reconnect the branch vessel essentially to the true lumen, bypass as needed, fem-fem, renal, mesenteric, and then in select cases, consider endovascular or open fenestration. I have a case where we cover the entry tear and for some reason the false lumen remained pressurized. So the first case to demonstrate this is a patient with an acute type B dissection. He had a witnessed cardiac arrest with successful ACLS. When he came in, this was his initial chest x-ray. After ACLS, this was his chest x-ray, so he developed cardiac tamponade that I can't explain fully. This is his upper aorta. You can see a very bad type B dissection with acute aneurysm. And this, this is another shot of it. He also had dissection extending into his left renal. And you can see in all of these cases, we should perform intravascular ultrasound. It's essential to know that you're intralumen. You can see the septum here, very mobile. So we actually did a thoracic stent graft, a pericardial window, and actually after placing the thoracic stent graft, the flow in the left renal was not adequate. So we actually then did a bridging stent to bridge that left renal to the true lumen. Second case to demonstrate this is a patient that came in with SMA, left renal, and iliac malperfusion. This is the initial aorta on presentation. You can see that this is actually all false lumen. The true lumen is completely compressed. We get absent filling of the SMA. A couple other projections here. And so this true lumen is very, very much compressed by that false lumen. In addition, the iliac was out. So this is actually the initial diagnostic angiogram. You can see we're in the true lumen. There's some filling of the visceral branches. We're not seeing the left renal. So this patient also had an aberrant vertebral artery. So we actually landed the stent graft just distal to that aberrant vertebral. Just covered the subclavian in this acute situation. And now, after placing that proximal stent graft, we actually have visceral flow. And then for the right iliac, we just placed bare stents to protect that lumen. This is a scan about a month out. You can see this is before and this is after. You have re-expansion of that true lumen. She post-operatively developed ileus for a couple days, but that resolved. She didn't require any bowel resection. The third case that I'd like to go over was a patient who actually had initially a type A dissection, but also presented with an elevated lactate, abdominal pain, and visceral malperfusion. So I work very closely with the cardiac surgeons when we get these kind of cases. This is another projection showing that type A dissection. And the false lumen is compressing that true lumen. So this is actually the initial diagnostic angiogram. Here, because the patient was going to be going to the operating room for an ascending an arch replacement, we chose a different technique. We actually went above the visceral segment with a outback, crossed the septum, snared that wire, and actually using a glide wire, pulled the whole septum down. So this is actually after the septotomy. We have visceral flow is restored. But now you have this big wad of intima septum right at the aortic bifurcation. Thankfully, we were able to manage this with some wall stents. So we placed an infrarenal wall stent down to the bifurcation and then extended wall stents into both iliac systems, restoring flow into the aortic bifurcation. The patient subsequently underwent an ascending and arch replacement. He actually had very significant mesenteric ischemia, had to undergo multiple bowel resections, et cetera, which is very typical of these situations. And then, of course, you got to keep bypasses in mind. We often will do femfems for isolated iliac malperfusion. If sometimes you just simply can't manage this percutaneously, and then rather than prolonging the mesenteric ischemia, converting to surgical bypass is sometimes necessary. So with type B dissections, especially those that are complicated, it's really a slippery slope. There are many different management strategies, and I think it's an area that's continuing to evolve, and there's plenty to come. Thank you very much.